Good morning, everyone. Today's my talk is on Havel syndrome, a rare ectodermal dysplasia with ocular and cardiac manifestations. Havel syndrome or AAC syndrome, ankyloblepharon ectodermal cleft lip or cleft palate syndrome is a rare autosomal dominant ectodermal dysplasia. It is characterized by a triad of ankyloblepharon ectodermal defects and cleft lip or cleft palate. First described in 1976 by Hay and Wells, this disorder involves abnormalities of the skin, hair, nails, teeth, and eyes. It is caused by mutations in the TP63 gene, a transcription factor critical for ectodermal development. A 2-day-old full-term neonate born via normal vaginal delivery was referred for evaluation of eyelid adhesion, facial anomalies, and cardiac defect. No family history of similar complaints. Similar condition, birth weight was 2.8 kgs, Apgar score were normal. The mother had an uneventful antenatal period with no teratogenic exposure or infections. Clinical findings, ocular findings, the neonate presented with ankyloblepharon filiform adnatum, thin bands of tissue partially fusing the both upper and lower eyelids. Ocular movements were preserved. Signs of conjunctivitis was present. Cornea was clear. Anterior segment was normal. Fundus could not be evaluated due to lid fusion. And coming to other clinical findings regarding face and skin, facial examination revealed incomplete cleft palate, which was and other ectodermal defects like sparse and wiry hair. These findings are consistent with the ectodermal dysplasia. Nails and teeth are not accessible due to age. Cardiac findings, 2D echo revealed moderate size ventral septal defect, which is 5 mm, left greater than right. Differential diagnosis of this case are ectrodactyly ectodermal dysplasia clefting syndrome, Rapp-Hodgkin syndrome, Chance syndrome, popliteal pterygium syndrome, and isolated ankyloblepharon. Havel's is distinguished by the presence of ankyloblepharon ectodermal defects and clefting in the absence of limb anomalies. Investigation, genetic testing, TP63 gene mutation identification should be done confirming Havel syndrome, and ultrasound B scan show normal posterior segment. ENT and pediatric surgery evaluation for cleft repair, and dermatology assessment for skin management, and cardiology ventral septal defect repair management. Ocular management includes lid bands are carefully separated using micro scissors under sterile conditions, and the feeding, NG tube feeding initiated due to cleft palate. Multidisciplinary follow-up with ophthalmology, plastic surgery, dermatology, and genetics. Genetic counseling provided to the patients. Discussion. Havel syndrome requires early diagnosis to prevent ocular complications and ensure feeding support. Ankyloblepharon may lead to amblyopia if untreated. Multisystem involvement necessitates coordinated care. Prognosis depends on severity of skin lesions and feeding difficulties. Genetic counseling is essential due to its autosomal dominant inheritance, so many cases are de novo. Conclusion. This case highlights the importance of early recognition of Havel syndrome in neonates with eyelid fusion and facial anomalies. A multidisciplinary approach ensures optimal outcomes. Ophthalmologists play a key role in diagnosing and managing ankyloblepharon to preserve vision and prevent complications. These are my references. Thank you.
A few things, just a point that I think you showed in the reports, and I could see the name of the patient. So whenever you're presenting, just ensure that you maintain the anonymity, because you're presenting in a public platform. Otherwise, very nice presentation. Yeah.
Just as a query, what was the need for doing a USG-B scan? You said USG-B scan for posterior segment. So if the cornea is clear and you are able to do a fundus examination, what is the role of a USG-B scan?
In my case, we didn't do fundus examination, ma'am.
No,
because of those lid adhesions, I haven't performed fundus examination, so I ordered a...
Once the band is removed, see, when you send a child of that small an age for a USG, it's not easy anyways. In fact, that becomes more difficult rather than just doing, it's not going to change your management. So the first thing is that you have to open up the lids and then you do a fundus examination. Okay. Because even, see, what will a USG pick up? Only something which is in the vitreous, or if there is a detachment. If there's an optic atrophy, you can't pick it up on USG, or there is a sort of choroidal lesion or something, you're not able to do that. So a fundus examination is required.